Hi, this is Christy Day, and I wanted to take a few minutes to go over the pulmonary part 1 with you. I met with the students last evening and my recording didn't work, so I'm going to re-record today. If you look at the topical outline, you will see at the top that you see on every topical outline that tells you what you need to know about each of the problems listed below. And I know we kind of get used to looking at this, but it really is important because these are your learning objectives. These are the things you need to. You'll want to think of each problem in terms of primary care and at what stage do you refer. Some of the problems you will refer immediately. Some of the problems you will refer at diagnosis. As soon as you figure out what's going on, you're going to switch straight to referral or hospitalization. But there are problems that you will manage in primary care only. So think of the differences there. Is it when do I refer, and do I do any management? And then there are times, for example, in when you have somebody with pneumonia or lung cancer, that you would have co-management. Let's talk about acute bronchitis first. Acute bronchitis you should be able to manage all the way from 1 to 11. And let's look at what we have in here. Okay, with bronchitis, we know that most of the cases of bronchitis are caused by a virus. Influenza A and B, parainfluenza, respiratory syncytial virus, adenovirus, rhinovirus, things like that. About 10% of the cases are bacterial. So that tells you know that an antibiotic treats bacteria and not virus. So all of the recommendations strongly urge practitioners to not use antibiotics for acute bronchitis unless there's something else going on, a secondary infection, suspicion for a bacterial infection, those type of things. So we know, and also you'll hear all kinds of different time frames for the cough. And sometimes you'll hear 2 weeks, they'll cough for 2 weeks, sometimes you'll hear up to 4 weeks. And so what you want to do is just know that they're going to cough for quite a while, okay? And I don't think anybody's going to ask you exactly the amount of time they'll cough. But that's going to be the chief reason that brings them into the clinic, usually is a cough. And then you'll have people that have bronchitis and also have asthma, or try to differentiate between the two. So the difference is that acute bronchitis, the cough, they don't have an underlying problem. They don't have recurrent respiratory problems. They don't have asthma-like symptoms throughout the year. They have they get a virus. They get the symptoms of bronchitis, which may be pain in the chest, burning in the chest, and and it's self-limiting. They may get airway hyperresponsiveness during a bronchitis, but usually they're pretty healthy and they don't have any underlying asthma. In asthma, what they'll have is recurrent lower respiratory symptoms. And if they get a virus or a bacterial infection, if they have asthma, it may go into their chest, so to speak, and they may hyperresponsiveness and trigger asthma-like symptoms too. Now in bronchitis, you're going to have exudates. You can have exudates, and in asthma you can have exudates. In bronchitis, you may hear some wheezing, and in asthma you can hear some wheezing. So just keep in mind that they sometimes will look very similar, but you're going to look for that underlying problem. Okay, and in people under the age of 5 years old, at less than 2, we see adenovirus is the main organism. From 2 to 5, we see RSV and para-influenza in ages 2 to 5. And, you know, in adults will get RSV too, and older people get RSV. But in little babies and little children, they get the bronchiolitis associated with RSV because of the small airways that they have. Whereas adults, they get the bronchiolitis, but it doesn't cause usually any kind of respiratory distress. In adolescents and adults, it's usually viral. 5% is Mycoplasma pneumoniae, and 5% is Chlamydophila pneumoniae. So they say cough lasts more than 14 days, then you're going to consider pertussis. Okay, so in an upper respiratory infection, when somebody has an upper respiratory infection without acute bronchitis, they usually have a cough for about 5 days. But a bronchitis cough is usually 10 to 20 days and may last up to 4 weeks. And what about purulent sputum? Is purulent sputum an indication of a bacterial infection? No, it's not. Purulent sputum alone is not an indication for antibiotic prescription. And antibiotics are not recommended in uncomplicated acute bronchitis, regardless of the duration of cough. So it's not going to help. Routine antibiotics are not warranted. This is from the American College of Physicians, the American College of Chest Physicians, and the CDC Get Smart campaign. So everybody's telling us no antibiotics. And they're indicated only in association with sinusitis or heavy growth on throat culture, if there's a reason to suspect a bacterial infection. And usually the management of acute bronchitis is symptomatic. Okay, so let's see what UpToDate says here. And UpToDate goes through some of the things that we just talked about as far as the bacterial versus viral, and the clinical features, talking about what you're going to see. Chest x-ray usually doesn't show anything. And diagnosis is made usually on a clinical exam and history and physical. And usually there's no testing involved. If there's any suspicion of pneumonia, go ahead and get a chest x-ray, just to rule out to zero in on your diagnosis. Sputum cultures, not recommended. I haven't seen this procalcitonin used much. Maybe y'all have seen that. I haven't seen it. So, but this is interesting. And then your differentials are there, and treatment is symptomatic. And some, from what I read, is that bronchodilators help in those people with any kind of chronic problem or hyperreactivity during the bronchitis with a short-acting bronchodilator. Sometimes oral corticosteroids will be effective. Those types of things. Let's see what UpToDate says. Now, I also have read that NSAIDs sometimes are effective for that cough, but I'm not sure if we're going to read that here. Okay, there it is at the bottom. We do not recommend treating bronchitis with antibiotics. Symptomatic treatment may include non-steroidal anti-inflammatory drugs, aspirin and acetaminophen, ipratropium, and you can use antitussives, but you'll want to use those mainly at night, you know, if they're keeping them up and things. And because if it's productive cough, you'll want them to kind of get everything out. You want them to produce that sputum and get it. Now, an indication for antibiotics in somebody with acute bronchitis is if they have another problem. You know, they can have acute bronchitis in the presence of, you know, a throat culture with the, you know, strep on it, or they can have an acute sinusitis that you decide that you want to treat with antibiotics, or they could have a pneumonia, and then that's a different diagnosis. You're not treating acute bronchitis with an antibiotic. You're treating those other problems as indicated with an antibiotic. Okay, so let's move on to asthma. And what I wanted to do is give you a chance to apply some of the asthma guidelines that you've been learning. And there's several asthma resources that I wanted to point out to you. They're available, and I know in your readings you've seen some of this stuff, but I wanted you to kind of see them. We have an asthma control test. I think that the top score is 25. And there's ways to interpret this. We'll have to look at what it means. You can see here that there's a paper version of it too. I've seen ones with little dots. And here we have an asthma journal. These are all resources for patients, and an asthma action plan. And this is usually green, yellow, and red. And I kind of like this one better than another one I'm going to show you. That's more of landscape. This is a portrait, and that kind of makes a little bit more sense to me. And then you can also print the test right here. So the asthma.com is a good resource for all of these documents that you want to look at. And it says if your score is less than 19, you're not as well controlled as you want to be. So if somebody's at 20, they're okay. So remember that. Okay, another resource you want to look at is they have a child version where it has little faces on it, and a lot of times, you know, the adult is going to be giving the information, but you can also print this one and it comes out with your faces, which is kind of cute. Stepwise approach to asthma. I know that you've seen this all over the place. It'll be an up-to-date. It'll be in your textbook. It's based on the 2007 National Asthma Education and Prevention Program expert panel, and so those are still the most current guidelines, and you will see these. So let's look at these a little bit. Intermittent asthma, step 1. Persistent asthma, daily medication. Consult with asthma specialists as step 4 care or higher is required. Consider consultation at step 3, and the reason you would want consultation is to both improve control and to maybe reduce the amount of medications. So you'll want to look at these medications, understand the classes, you know, learn a few, maybe the prototype medication, and you'll want to be able to apply these guidelines. So each step: patient education, environmental control, and management of comorbidities. So these are kind of complex. You know, to me, this is a very complex algorithm. You've got different medications, but you're adding. So if you look at step 1, which is intermittent asthma, the recommended treatment is short-acting inhaled beta agonist, which is the SABA, which is albuterol. But you'll also notice that right here it says quick relief medication for all patients. So you're going to have the SABA as needed for symptoms. And then it gives you some more information about that. When you go to step 2 and the SABA is not listed, look down here and it shows that SABA is needed for all levels, okay, for immediate relief. Okay, so step 2, and you're going to see the low dose inhaled corticosteroids. So we're going to be adding that on, or cromolyn, leukotriene, or these other medications. Remember, theophylline is an older medication. It's often considered cheap, but it is in the same class as caffeine, and so it has those type of side effects with irritability, excitability, maybe increased heart rate, things like that. Also, theophylline has a narrow therapeutic range, and so you would have to do blood levels, and so that changes it from a cheap medication to an expensive medication right away. Okay, step 3, you got the low dose inhaled corticosteroids plus a long-acting bronchodilator. This is the scale for people over the age of 12. If you have people under the age of 12, this LABA has a black box warning. So You'll have to look at that. Or you can do a medium dose inhaled corticosteroid or some of these other medications down here. Step 4 is a medium dose inhaled corticosteroid plus a long-acting bronchodilator. And then you go on up to high dose with oral corticosteroids. So step up if needed. First, check adherence, environmental control, and comorbid conditions. This is multifactorial. We're going to look at asthma from several measurements of control. Multiple measurements of control. We're going to look at function, daytime symptoms, nighttime awakenings, use of their quick relief, SABA, patient report of self-control. How are their activities? Are they missing work or school? What is their lung function? And utilization of health care resources. So there's a lot going on with asthma. It's multifactorial. So the important thing is our assessment. And remember that when you listen to somebody with asthma, their lungs may sound fine. The physical exam of the lung is not really a measure of their asthma control or their lung function. Okay, so let's look at asthma severity. This chart a little bit. So your evaluation of the asthma and their current control and severity in lung function is the most important thing that you're going to do, and it's your diagnosis. Where is your patient? And then that determines the steps. So you have to go through all this up here before you can get down to going through those steps that we saw. Greater than 12 years, and you can look at the one for less than 12 years, and I recommend that you do. And some people say this is the chart of twos. So, mild, moderate, severe symptoms. You know, how often? Nighttime awakenings. How often are they waking up? How often are they using their SABA? Are they able to do their normal activities? And then lung function. And this is really important because something that puts people at risk for asthma exacerbation and death is not having their measures, not having their lung function, not doing their peak flow meter, or having pulmonary function testing. Other things that put them at risk are low socioeconomic status, illicit drug use, psychosocial problems, comorbidities. But what I find interesting is that people that underestimate their symptoms or their level of at risk for acute exacerbation and death. You know, how are they doing, and do they know how they're doing? What is their self-report of control? And I find that that's an important component, because recognizing your level of control is super important to stepping up, and that asthma action plan allows the patient to step up. You know, they have the action to take and know when to step up to have better control. You know, asthma can change the lungs. If it's not treated properly, it can remodel the lungs, and it can change the lung function permanently. So we want to have really good control. And measurement of lung function. What you're going to want to do is get spirometry or peak flow meter measurements. You want to have some objective measure of pulmonary function. And if you look at pulmonary function testing, for asthma, what you're really going to be looking at is the FVC, forced vital capacity, and the FEV1, which is the forced expiratory volume in 1 second. So the FVC is if they take a huge breath, blow it all out at one time, which usually takes about 4 to 6 seconds. And then also the FEV1 is in 1 second. And then they do they divide it. They do math, and they come up with a ratio. And so that's what we're going to look at. If it's below normal or less than 0.7, then that's the cutoff. There is the 0.7. So if you think about pulmonary function testing, sometimes you'll see on these spirometry results obstructive disease or restrictive disease. And remember that when they do these tests, what they'll do is they'll treat with albuterol in the middle and see if there's any reversibility, for one thing. But also they'll put in the patient's weight and some data about them so that they can calculate these things properly. And if you see the word obstructive disease, then this is the airway obstruction in the bronchial. The obstructive disease, air cannot get out, so it's a mechanical problem. It won't pass through. That's obstructive. It's a roadblock. But in restrictive disease, that's in the alveoli. In that case, you know, sometimes in COPD you'll get consolidation down there, and the alveoli, you know, you get consolidation and they can't be filled with air. And so that's called a restrictive disease. The FVC is how much total volume are in the alveoli, and it's less than 80 80% is the less than predicted, that's the cutoff. And then FEV1, the cutoff is 0.7, and that's how much air can be exhaled in 1 second. Let's go back to our chart here, and you can see that the chart continues down, and you have intermittent, mild, moderate, severe, and then you go down and it tells you the steps. Okay, at the bottom you'll see the steps right in here, and you follow those steps. And what's important to remember is that, you know, this is a clinical judgment, and if, let's say you have a patient that goes back and forth between these two levels of persistence, then you're going to take the highest level, okay? And it's a clinical judgment. If there's no step, consider oral systemic corticosteroids in 3, 4, and 5. So, but if you look at the steps, it doesn't say oral corticosteroids in any of these areas. But remember, it's a clinical judgment. So you'll want to consider those oral steroids if they're needed. If you feel like you're having an acute exacerbation that's going to need steroids, then you're going to give them. Let's go on, and I want you to take a minute to practice this algorithm. So you have a 19-year-old girl, female, Sarah. She's seen in the office today because her asthma symptoms have been worse over the past few months with increased use of albuterol inhaler. Sarah's asthma treatment plan is consistent with which level of asthma severity? What step is she being treated at? How would you see that? And what additional information do you need to know to determine these levels? So go ahead and take a minute and look at the charts, the asthma severity, and also the algorithm, and see, what are we treating, her level of severity, what do you need to know about that? So I'm going to pause for a couple minutes and let you get your list together, and then I'll be back. Okay, so here's some information about our patient. Prior exacerbations, yes, she's been on oral steroids 3 times in the past year. Has she had any prior emergency visits or hospitalizations? She answered no, but she'd had urgent care visits for all of her exacerbations, and that's where she receives most of her health care. Poorly controlled asthma, yes, she experiences asthma symptoms every day with more severe symptoms over the past 2 months. How many times a week does Sarah use her short-acting bronchodilator? Has it increased? Yes, she's using her SABA 4 to 6 times per day over the past 2 months. She still feels some asthma symptoms even with her SABA use. Does she awaken at night? Yes, she awakens 3 to 4 nights per week, and she uses her SABA when she awakens, and usually she wakes up because of coughing. Do her symptoms interfere with her normal activities? Well, sometimes. She attends work and school, but sometimes she avoids activities like dancing or riding or bike riding with her friends. Does she have a history of oral systemic corticosteroids? Yes, 3 times in 1 year. And what is her FEV1? Well, she had no prior measurements, but in the office today it's 58%, which is also, when we asked her about her control, she said, well, it's pretty good, you know, it's okay. It's been a bad, you know, the past couple of months, but you know, it's okay. It's not, she's not in bad shape. So, but by her measures here and by her risk factors for acute exacerbations and her current level of severity of asthma, she is not well controlled at all. So based on this, where is she on the severity chart? Let's take a look. Okay, here we are. And remember, when patients bounce back and forth, that means that we're going to go with the higher level. So you can go through these, take a look, you know, you should have this printed out as you're studying, and figure out where she's at on here. So you might find her in severe on many categories, and that's probably where I would put her too. And where is she being treated right now? What level of control is she? What level of control is she at? What level of control is she being treated at? She's being treated right now. What we're saying is that she has persistent asthma that is severe, right? And she's being treated as if she has intermittent asthma. Okay, so she's not at the right level. And what level are we treating her at? We're probably going to go with step 4 or step 5, right? And we also can consider oral corticosteroids. So you can go through here, and what I want you to do is I want you to look at the list of asthma medications, of bronchodilators, and I want you to kind of become familiar with some names of long-acting bronchodilators and controlled inhaled corticosteroids, and learn those names and the long-acting bronchodilators and the short-acting bronchodilators, those type of things. I want you to go through and learn some names of those medications, and also read in your pharmacology book about the other types of medications. Okay, so you'll determine her control, and usually we want to see them back in about you know, depending on your clinical judgment, but at least every 4 to 6 weeks for their, you know, during this period while we're stepping up and trying to get them under control. Okay, so let's move on to chest pain or non-cardiac chest pain. Now, we talked a lot about chest pain in our other course, but what we want to look at now is we want to look at a diagnostic approach. What I'm looking at, you were assigned Botaro, and for the ease in looking at it, we're going to go to UpToDate. And remember that UpToDate includes information from multiple resources. It's kind of like when you write a paper and you look at everything out there. You're going to look at all of the what you can find on the results, you know, what you find about that topic, and then you synthesize that information and make some recommendations. And that's what UpToDate does. They have authors and they look at everything, and so and then they may report on everything. So within an UpToDate article, you may get multiple guidelines, but if you go to the original guidelines, you're going to get one guideline and one recommendation. But if you go to UpToDate, you're going to get several. So, but as far as chest pain, evaluation of differential diagnosis of people with chest pain, you know, when you look at chest pain, what you're going to want to do is you're going to want to have a broad stroke. You're going to want to really think about everything that could cause that chest pain. Don't zero in too quickly. You know, just be sure and think of all the reasons, whether it be cardiac or non-cardiac chest pain. Okay, so let's just, what I'd like to do is just kind of go through some of the differentials and think about them. Musculoskeletal pain, what you're looking at is usually like a strain, a fracture, costochondritis, and this is reproducible. You press on it and you can cause pain. We're going to look at pulmonary causes. Pneumonia. Pneumonia usually has that classic kind of when they breathe in on one side or the other, they have pain with inspiration. And that you can have pain with pneumonia. You can definitely have pain with a pneumothorax. And pulmonary embolism. Pulmonary embolism, they usually have a lot of shortness of breath with that. That they really have trouble even taking a breath. Pleuritic pain, you can have asthma. I don't know too many people that have asthma pain, chest pain with asthma, but I guess it would be possible, more like a chest tightness. And then there's also bronchitis. People with bronchitis usually have a burning sensation in their main bronchiole, and it would be worse with the cough. They'll feel it when they cough. And then pulmonary hypertension. So those are kind of some of you have musculoskeletal, you have pulmonary causes, cardiac causes, and then general other reasons you might have chest pain, like a malignancy, shingles, maybe anxiety, depression type of thing, maybe a heightened visceral sensitivity. They just feel a lot of stuff more than other people, and maybe drug induced. It can also be GI, it can be the gallbladder, it can be esophageal pain. Esophageal spasms can be really painful, and it can mimic heart pain. So just be sure that you have those reasons on the radar for non-cardiac chest pain. You're gonna want to know that in evaluating chest pain, your history is absolutely history and physical are the most important thing in evaluating chest pain. Okay, next we have a chronic cough. So usually what you have in people with chronic bronchitis is you have somebody that's a smoker, and every morning they wake up and they've got a lot of sputum. They're coughing and spitting and kind of clearing that sputum, and that's kind of what you see. And they probably have COPD. If you do your pulmonary function testing, you would probably find COPD, and probably. But a lot of times these people are, in their 50s with the chronic bronchitis. They're in their 50s. They're working. They don't perceive any change in function, and but they have really good muscles and they're breathing well, and you may still see COPD changes on the X-ray of the flattened diaphragm, things like that. And you may diagnose COPD by spirometry on these patients. So with a chronic cough, you need to know the definition of that. How long is the cough? How often do they experience it? It's usually not productive. We usually have, with just a chronic cough, without chronic bronchitis, we usually don't have a lot of production. So let's look at what UpToDate has to say about a chronic cough. Subacute chronic cough is present longer than 3 weeks, subacute 3 to 8 weeks, and chronic more than 8 weeks. Okay, acute bronchitis, I think, is every day for 3 months, 2 years in a row. And so there's a little bit of a difference there. And then you have the different reasons for the chronic cough. You can have it like a postnasal drip. It can be asthma. It can be reflux. The reflux comes up and it stimulates a cough. Respiratory tract infection, ACE inhibitors, bronchitis, lung cancer. There can be all kinds of reasons for that, and you need to think about those. So let's look at treatment. And what you're going to do with the chronic cough is you're going to treat the underlying problem. That's the main thing. So whatever is causing the problem, you'll want to identify that and treat the underlying problem, the thing that's causing the cough. There's different antitussive, so you have dextromethorphan, codeine. The evidence is limited. Morphine. You have these different cough. So just go ahead and look through those. But mainly you're going to identify the underlying cause and be able to understand, is this a chronic cough, chronic bronchitis, acute problem, those type of things. Okay, COPD. let's look at COPD. Now, COPD I think is a little bit, what I would say, easier than the asthma, because the algorithm is so much easier to follow. It's pretty straightforward. And with COPD, what we're going to do is we are going to want to prevent exacerbations. That's the main thing. Exacerbations, you know, shorten their life, basically. So we have the gold standard, and this for chronic obstructive disease, and this is everything in a easy to read document. So it's got this type across it, and I think what you're supposed to do is you're supposed to buy it. And then, but it's available for us to read on here. Indicators for considering a diagnosis of COPD. So you look at these: chronic cough, and a history of exposure to risk factors, tobacco smoke, that occupational things. You'll look at those, and spirometry is required to make a clinical diagnosis of COPD. So when you have a patient that you suspect the COPD, you need to get that spirometry, and then that will below 70 and on the ratio 0.7 is a diagnosis of COPD. Okay, so then you're gonna go and you're going to determine the level. The classification of severity. Just like in asthma, you want to classify your severity of airflow limitation. When you think of asthma, it's a reversible airway problem, and in COPD, it is not reversible. So they have the COPD assessment test, the CAT, and the COPD questionnaire. So some of those are used. You're going to assess symptoms that way. And then the modified British Medical Research Council scale, it talks about breathlessness. So those are all included in kind of the assessment of COPD. So what you want to do is first look at the airflow limitation and determine where they're at with their ratio here, okay? And then you're going to assess risk of exacerbations. Have they had worsening symptoms? What is their risk for an acute exacerbation? And how many have they had? How many hospitalizations? And then comorbidities, you're going to look about what's going on with it. Do they have CHF, lung cancer, anything else along with the COPD? So then you can go down to the rubric that you put on their symptoms, airflow exacerbations, and then you're going to get your combined assessment, and you're going to grade your patient. You're going to place them on one of these levels that is you can follow the algorithm of management. So let's say your patient is at a level B, then based on the table there. But COPD is a lot about meds, so this is kind of turned over. Patients here. And what you'll notice is you have the short-acting anticholinergic. And the short-acting anticholinergic is a bronchodilator, just like a short-acting beta agonist. They work along two different pathways. And these anticholinergic bronchodilators are essential to management of the COPD. And so we haven't really seen those on the asthma management. So there's your difference. But you're going to use a short-acting anticholinergic or a short-acting beta agonist. Anytime you're adding in a short-acting anticholinergic, you're going to do one or the other. So if our person is at level B, then that is a long-acting anticholinergic or a long-acting beta agonist. What they know is that patients like these long-acting anticholinergics and beta agonists because they last longer. They feel better longer, and so they perceive them as working better. So what you'll see is a combination in the drugs. You'll see a combination of a short-acting anticholinergic with a long-acting beta agonist. It's because they get that first opening up, and then they get the long-acting. So if they take the medication, say every 6 hours, then they're going to have a kind of a continuous bronchodilation. So those work really nicely. And then you'll see in the on the inhaled corticosteroids. Now you can go down, and I know we've passed around a few charts on this. you're going to want to learn some of these names. You know, the extensions on short-acting versus long-acting beta agonists, they all end Terol. So you need to kind of learn the main ones like salmeterol, formoterol. Those are long-acting beta agonists, and then albuterol for the short-acting. Those are probably the prototype drugs that you'll want to remember. Also, in the anticholinergics, you're going to look at the ipratropium versus the tiotropium. Those are kind of the prototypical drugs. And I really like this chart because it also has a solution for nebulizer here. So it not only does it give you the inhaler, gives you the nebulizer availability. So, but what we know is that when they take an inhaled product, an MDI inhaler versus a nebulizer, they're going to get a lot more medication with the nebulizer. It can be up to 10 times as much delivered. So if you have somebody that's really, that's got a problem using an MDI and they need education, that's key. But also, if they need a good amount of medicine and you want to make sure they get it, then you can use a nebulizer for a short period or every day, either one. Sometimes in older people, we use them, always do nebs because they can't manage the MDI. Okay, so that's basically it with COPD. You want to prevent exacerbations, you want to do your education, and you want to, follow the algorithm, assess their level of control, their severity, categorize them, and then manage their care according to the algorithm. So it's a lot of medication. Okay, so now dyspnea. Here's the up-to-date on dyspnea. And dyspnea is actually a symptom. And if you look at the ICD-10 coding, it specifically says it's a symptom. And so we can use that. If we don't have a diagnosis, we don't know what they are, we're working up their symptom. We're looking for use that, and then you'll order your tests related to what you're trying to rule in or rule out. So sometimes when you're matching up your assessment plan, my assessment, I think it's COPD, but I'm not sure. But I know that they have dyspnea, and I know that they have tobacco abuse. So there's those two things. And so under dyspnea, you can use that as a medical necessity to order your tests. Okay, so you can see here heart failure, anemia, deconditioning. You can have cardiac problems, respiratory problems. There's all kinds of reasons. So look at this again with a broad stroke and see what you need to do and for your patient to work up and zero in on the reason for the dyspnea. Okay, and then we have hemoptysis. So you're going to want to look at the difference in the etiology and evaluation of hemoptysis in adults. Remember that it's usually, there's a difference between GI bleeding versus respiratory or pulmonary bleeding. Usually the GI bleeding is coffee ground, a little darker, and the pulmonary bleeding is usually bright red, and it can have some bubbles in it or some foaming because of the air. But also think about, bloody nose is things, where is it actually coming from? But people don't always, they're not able to quantify the amount of blood, but, try massive hemoptysis, I think anybody can kind of figure that one out. And then look at the causes, airway, you're going to look at bronchitis, neoplasm, foreign body, airway trauma, all kinds of infections, and just broad stroke. If you look at the ICD-10 code for hemoptysis, you'll see that this is a coughing or spitting up blood from the respiratory tract, and it's a finding. You have to get to the underlying cause. Hemoptysis is like chest pain, shortness of breath. It's a symptom, a sign or a symptom that we need to find the underlying cause. Now we have obstructive sleep apnea. So let's take a look at that. You know that education is the key to management of obstructive sleep apnea. We have lifestyle modifications to treat it. Sleep apnea is a really serious problem because it shortens lives. and look if your patient is, you know, having daytime sleepiness, hypertension, those things. Always ask about their sleep. But you can see that education to change behaviors is the most important thing you can do. Weight loss and exercise, sleep position, alcohol avoidance, all of those things that we do to help them. You know, medications can help, but the mainstay of treatment is CPAP, and y'all know that. And we also know that that compliance with CPAP is very low. I personally have a son-in-law who's about 35 that has sleep apnea, obstructive sleep apnea, and does not use a CPAP because it makes him look like an elephant. He's embarrassed of it. What can you do? People are going to do what they're going to do. So, you know, if they won't do the lifestyle modifications, or you might do it at the same time. You might do lifestyle modifications plus the CPAP. So look at diagnosis on that and education. As far as smoking cessation, know the NSPSTF guidelines. And when do we screen? How do we get them to, how do we encourage people to stop smoking? Should we encourage them to stop smoking? Those type of things. What are the medications that we use? You know, you can use, I think Wellbutrin's one of them, the Buprion, and also Chantix. Major side effect of Chantix is the nausea. And then we're going to, you know, there's a mnemonic there for assisting them to quit. We want to assess their readiness, all those type of things. You know, sometimes patients will say, I don't want to quit because I don't want to gain weight. And they're right. They may gain weight because the tobacco suppresses the appetite. So it's not just having something to put in their mouth, oral stimulation. It actually is the tobacco suppresses their appetite in a way. It's on a neurological level. So we'll want to see if they're ready to quit. Set a date, all of those things, behavioral counseling. So just kind of know that you want to bring that up and what NSPSTF says about screening for tobacco use. And that's all I have for today. I'm going to try to record something for part 2 to kind of give you a little direction for your studying. And thank you very much.